Hello, everyone, and welcome to our webinar, CMS Billing Regulation Review. All lines have been muted. The webinar will last 30 minutes, and we will have dedicated time after the presentation for Q&A. If you have questions throughout, simply type them in the comments section, and we will address them during that time. This webinar is being recorded and will be sent to each participant afterwards. Our speaker for today is Ann Bina. Ann is a member of the Practice Optimization team. Prior to joining, Ann served as the Chief Compliance Officer for a consulting company with a primary focus on vision services. She previously worked for over 20 years at a Western Wisconsin healthcare system, serving as the manager of coding before accepting the Director of Patient Access role. She is certified in healthcare compliance through the Healthcare Compliance Association and holds a variety of AAPC certifications. Thank you for taking time out of your busy schedule to join us today. At this time, I will turn the webinar over to Ann.
Thank you. Welcome, everyone. I joined CV Global just in January, so I'm really excited that I'm able to present the March webinar. And you'll find out as I talk that I actually really love regulation reviews. So as geeky as that sounds, it's something that I've always liked to dig into the rules to see how everything goes. So I just want to start out with a quick disclaimer. We all know that healthcare in general, healthcare regulations are not black and white. So today we're going to talk about a high-level review of these regulations. But if you have questions that are specific about a situation or something that you just want to clarify, feel free to reach out to any of the team members and we're happy to help you. There's ways to submit questions online here, and I think you'll be contacted afterwards. If you have other questions, you can contact us. So just make sure that you get your questions answered. We don't want anybody out there that maybe want something clarified. So we're going to talk today about the background of how we got to these Medicare regulations. And then we're going to talk about just a few of them because of the time constraints of a webinar. We're going to talk about signature requirements and scribe documentation requirements, addendums, billing family members, and the appropriate completion of an ADN form. And I picked these 5 or 6 things because it's important in an audit that all of these things are in place. All of these things can actually cause money to be recouped in a payer audit. And it's not just Medicare, it's all payers. Although these regulations are specific to Medicare, a lot of other payers have the same or similar regulations that they need you to follow. And so by looking at these, it actually drives more questions onto your commercial plans also. So let's start a little bit with the background. Medicare was signed into law in 1965, and in 1972 it expanded to include all disabled people. It includes Medicare Part A and Medicare Part B, which is the hospital and the outpatient care. In 1997, Medicare Part C, or what we know now as Advantage plans, the Medicare Advantage plans came on board. And in 2006, the Medicare Part D plans came on board, or the drug plans, the drug coverage. Medicare covers approximately 60 million people this year. But you know that all of these plans cost money, and the more they increase the benefits, the higher the cost is. Now, unlike commercial insurances, Medicare is funded a lot of different ways. Commercial insurances are funded by the premiums that the patients pay or the subscribers pay. Medicare funding actually includes payroll taxes, which we all pay a part of, premiums that the beneficiary pays, earned interest, and then congressional fund authorizations. Now, they're trying to make a program that is robust, that will help Medicare patients and keep everyone healthy. But with increasing Medicare populations and with increasing healthcare costs, keeping those premiums low enough for Medicare beneficiaries who are no longer working to afford them sometimes can be a challenge. And so you'll see in a few minutes both how they are spending their money and then how they're finding fraud and abuse and getting money back. So Medicare in in 2017, Medicare paid out in different services for their beneficiaries about $680 billion, billion with a B. And so that includes drugs, nursing homes, hospital, home health, anything that Medicare covers. And we all know that Medicare does not cover everything. There's certain things the patients are still responsible for. But $680 billion, that's a big budget for a health insurance plan to have. In 2017, through Medicare fraud, they recovered $1.8 billion. So while that's not very much, it's only a 0.2 percentage points of what they spent, just the amount of money recovered by fraud actually can fund, potentially another part of the program. And so the interest in collecting money that's billed incorrectly or recovering funds that are billed incorrectly have increased, and many of us are experiencing those types of audits now. You have the Medicare Part C audits or the Advantage Plan audits for risk adjustments, and we have just tons of different things that come. One claim can be denied, 2 claims can be denied, and then if they see a trend, they might request notes on many of your claims. So it's important that we're aware of as many of the regulations as we can be, and as our role as Medicare providers, it's our duty to be aware of them. So webinars like this help share that information at a high level, and I think that's invaluable to our providers. So regulations were created not only to prevent fraud, for sure to prevent fraud, but to control the cost. They provide transparency and consistency so patients and providers understand or have the information available to understand what's paid and what's not paid. And it provides guidance such as medical necessity and billing, how we should do things, what modifiers to use in certain services. If you dig into the regulations, there's all kinds of billing information available in there that can answer almost every scenario that you can think of. But they don't make it easy for us. They've created these guidelines on a national level, which means Medicare themselves have guidance, so it covers all of the states. But then Medicare carriers or MACs, the Medicare Administrative Contractor or Carrier, they actually can create their own rules. So what might be on the national level, it might be different at a carrier level, or the carrier might be silent on a topic and we can't find any regulations at all for that particular state or area. But then when you go to another state or another Medicare carrier, they actually have guidance. So they don't make it easy to find the best way to do things or the correct way to do things, and you have to be able to justify why you bill or why you do what you do. So we're going to start out with these regulations. The first one is the signature requirements. Now, signature requirements can be 3 different ways. The first one is the most common now, is electronic. And that's because the increase in the electronic health records, the increase in technology allows electronic signatures. It's much easier for everybody. It's nice to track. But there's a catch here that you have to be very careful of, and that's that you should never share your sign-on information with anyone. And if you're a provider, you shouldn't give your sign-on information to your tech or to your scribe or to another provider, because you're responsible for everything that's in that medical record under your signature. And so if your relationship with your scribe, for example, would go south and the scribe gets angry and it comes to a termination or something, just remember that she has your sign-on information. And so you want to make sure that you protect that information just like you would a handwritten signature. You didn't want anybody forging your handwritten signature. You don't want anyone using your electronic signature either. So if you're in the habit of sharing that signature, I would create a process in your office, or I encourage you to create a process in your office that everyone signs on under their individual sign-on and password, and let the process create itself so that who's ever documenting the record is logged in and documenting, and then the provider signs on and signs it, and stay away from that sharing of any of that private information. Signature requirements can also be handwritten, and that's a mark or a sign by the physician on a document. Paper records are still allowed if you have orders that you write and scan. A handwritten signature is fine. As you scan it in the medical record, it's available. If it's in your paper record, it's available. But regardless of who writes the medical record entry, the entry must be authenticated by the provider, and you have to review it to make sure that it is what you said it was. Because at the end of the day, your name is on the billing, the provider's name is on the billing, and the provider is taking responsibility for those charges. And the final way that you can sign is through a stamp, although it's very rare. It has to be the provider has a physical disability and can prove to a CMS contractor if they're asked that they're not able to sign due to that disability. So the signature stamp, which used to be popular many years ago, is not very utilized anymore. Late signatures shouldn't be added to the medical records, and the definition of a late signature is anything beyond the short delay that occurs during the transcription process or the documentation process. So if you think about that, it probably is not more than a few hours, 24 hours, by the time that you have all of the information you need to close that chart out. So anything beyond that reasonable short delay has to have an attestation to say why it's late. So progress notes all must be authenticated. All documentation of what you provided or what you ordered to the patient has to be authenticated by that signature. And if in an audit you send that signature information in, or you send your progress notes or your orders in and they're not signed, that's a reason for Medicare and other payers to request money back. A signed note is not considered valid in an audit. And the nice part about the EHRs are that it makes life a little easier. There's boxes you can check. You can create your templates easier. The flow should be better. But on the other side of that coin, it's all trackable. So they know now when you sign a record. They can tell the date that you signed a record. They can tell the date that you put that order in. And so you want to be very careful that we're not trying to rig the system at all, that we just create processes within our office that once the documentation is done, it's signed, and then it's billed, and everything is good. The signature requirements are a national guideline, but the attestation for a late signature can be carrier or MAC specific. And so if you have late signatures through a process issue or through something happened, technology maybe broke down and you had late signatures, you have to go through your MAC or your carrier to see what they want you to do. This is just one example of an attestation for a late signature. And it just says, that it's late, that it's true and accurate, and this is why it's late. So something like that is acceptable. It's just that they don't want to see that on every record. They want it only in those exceptions, the cases that are exceptions. All right, scribe documentation. Just a quick review, the scribe does not act independently, but they're really documenting what the provider asked them to document, what they would have normally dictated or written into the EHR themselves. Scribes are not providers of services, so even though they're doing the whole note and writing everything down, the provider's signature is saying that I reviewed and agree with everything that's documented in this note. When a scribe is used for documentation, we encourage you to have them put their name and identify themselves in the documentation. CMS, at a high level, CMS, does not require the information to be in the medical record. The scribe's name doesn't have to be in the medical record. However, there are MACs that may require it. And so we encourage everyone to just get into that habit to do it. The provider's billing note, whatever blank acted as a scribe for this encounter on this date. That just allows, if you don't have any place where you document it now, it just allows it to be part of the medical record. And then if you come across a payer that requires that identification, it's there and you don't have to worry about it. And I expect that we will see updates on this guidance in the future that will require the information to be in the records anyway. So if you're not implementing and doing that now, it's a good time to start it. Addendums. Addendums have to be dated with the date they were put in the medical record, whether it's a paper record or an electronic record. They have to clearly and permanently identify what changed, the date, and who put the information in, and then it has to be signed. When you put in addendums for payment, for example, if you've gotten a denial and you're putting in an addendum now to correct something so you can resubmit the claim, I caution you to use that sparingly. That raises red flags when diagnoses or procedure codes and things change on medical records. And so you want to be careful when you do addendums for billing purposes to outline, diagnosis XXX was inadvertently omitted from the original note or something like that, to kind of explain what it is, because you don't want any payer to think that you do addendums just to get paid. But you want to make sure that they know that you're doing addendums to support the medical record. And it's always been my philosophy, the medical record is used for continuity of care first, risk management second, and then for billing, quality, and all of those other things. So the first thing you want to do is make sure everything is documented to take care of the patient. And the second thing is make sure that it's documented to take care of you in case that that patient ever ends up in a risk management situation. My very favorite regulation and the one that causes the most questions are billing for family members. And regardless of how often I've presented this in the past at my other places of employment, people are continually surprised by it. But Medicare, and there are other payers that follow this guidance also, have created regulations to say, you know what, we're not going to pay you for seeing your family members, your immediate family members, because if you were to see them and they didn't have any insurance, you probably wouldn't collect any money from them anyway. So why should Medicare pay you for those services? So that's the intent of this exclusion, is something that you would normally provide for free. Many times Medicare is seeing where the services are provided, Medicare is billed, but then no co-insurance or anything is collected from the patient. And so they've identified this as an exclusion to the Medicare allowances for charges. And they identify family members as a husband or wife, so your spouse, your parent, your child, your sibling, your step-parent, stepchild, step-brother or sister, father-in-law, mother-in-law, son-in-law, daughter-in-law, brother-in-law, sister-in-law, grandparent, grandchild, or the spouse of a grandparent or grandchild. So it's pretty broad what they've identified as your family. And they even go on to say that in the event that your step relationship or your in-law relationship isn't in place anymore, like due to divorce or something, it doesn't mitigate the family member definition. They're still considered a step or an in-law. So practices should create a process where you're not billing for family members that you're seeing. Whether it's a tracking code or some other method, so you're not, in the event of an audit, you can show that you're not billing for these immediate family members and hence meeting the guidelines outlined by Medicare. And finally, we have the advanced beneficiary notice. So the advanced beneficiary notice is a Medicare fee-for-service form. So it's people coming into your office with Part B Medicare, the new cards with the long, awful numbers on them. Those are your Medicare Part B patients. And to fill out the advanced beneficiary notice, it has to be complete in order to be valid. And so all of those markings there, A, B, C, and then I have D as all the circled ones, have to be complete. So you need your name and address of the clinic up on the top. You have to have the patient's first and last name. You can put an ID number on, but it is optional. They do not want your Social Security, the patient's Social Security or Medicare number on there. D, and you have to have D all over, you'll see all the Ds, is the item, service, or test that's considered not covered. So let's say that you are performing baseline photos. The patient is coming in for just a wellness exam, their annual exam. You're going to do photos because the patient asked you to, because their neighbor had it done or whatever. And you know that it's not going to be covered. You have to present that Medicare patient the ABN form. So your D would be fundus photos or OCT or whatever the test is that you're performing. You have to have the price in box F, and in box E, it's why it's not paid. Medicare doesn't pay for this for your condition, or Medicare only pays for it once a year. You go on to F, the estimated cost. The patient or representative must choose an option in box G, so the form has to be filled out before you hand it to the patient, but the patient has to choose the option in box G. H is optional. It's completed only when other information is required. The signature of the patient has to be on the form, and it must be obtained prior to the service. So you can't perform a service and then have the patient sign a waiver. They have to be able to decline the service if they feel like they don't want to pay for it out of pocket. And the signature should be completed by the patient, or it can be completed by you, but it has to be completed before you give the patient a copy of the form. It's a requirement that patients have a copy of the form. So if you have an electronic ABN, you have to print out a copy once it's signed for the patient. If you have a paper one, you have to make a copy or have a duplicative form in order for it to be valid. And then when we submit charges, we actually modify the code with a modifier. So GA says that I have a signed valid waiver on file. And if you say that and you're audited and you don't have a signed valid form on file, they can request the money back. And so that's why it's so important to have these filled out. Now, once again, they don't make it easy. So if the beneficiary refuses to sign, but they really want that service done, so let's go back to those screening photos. She insists on having the service done, but she won't sign to say she's financially responsible for it. You can make a note of that. The staff in the office can make a note of that on the ABN form, and have the witness sign it, and then it's considered a valid form. So as long as everything else is filled out and you've witnessed that the patient refused to sign, you can still put the GA on there and send it to Medicare, and it will be denied as patient responsibility, or send that charge to Medicare and it will be denied as patient responsibility. But if that beneficiary refuses to sign, you really should consider not offering the service. It's going to end up being, if you don't fill out the form right, or if you don't get a form at all and you don't witness that it's not signed, it'll end up being the clinic's responsibility, and you'll have to write it off at the end of the day. So I feel strongly, I want to tell one more thing. Medicare Advantage plans do not use ABN forms. Medicare Advantage plans typically have their own form that they use. So you may have to do some research to figure out what form is required by any Medicare Advantage plan. And commercial payers often have their own forms or just require a standard clinic form to be signed. If you can't find specific instructions on what form to use, just use a generic one for Medicare Advantage plans or commercial, because at least you've made the effort to have it signed, and you can have that on file in the event it's questioned. So we really went quick over the regulations just based on time, but I want you to know that I truly believe that regulations are important in healthcare and in billing, in the billing world, in the business side of medicine. And I believe the intent of a lot of the regulations that are created are really good. Sometimes I believe that there's not the expertise at the Medicare level to implement all of these policies in a manner that is easy and cost effective. But I believe the intent is good, and it's up to us to make sure that we understand and can support these policies so that our billing's correct and things get paid the first time. So with that said, there are the references I use, not very many, mostly Medicare. And I'm going to turn it back over to Teresa.
Thank you, Anne. I just wanted to highlight on a couple of topics before we look at questions. Our next webinar is scheduled for April 25th, and that will be with Laura Waltz. And what she's going to be talking about is bulletproofing the MIPS audit file. So she's going to touch on understanding the audit, the documentation requirements, how to avoid red flags, and topics along that line. So if you are interested, go to our website, click on webinars, and register for your link. And then the next reminder I wanted to give everybody is related to our user summit. Our user summit is coming up in the first weekend of August. We still have early registration rates that are going on. You can learn more at eclsummit.com. And if you bring 3 or more staff, we are still giving a $50 rebate per person off of each of those registrations. So we would love to have you there. And now I'm going to turn to questions. The first one we have that came through is, do you need an ABN for non-covered services by Medicare, specifically for refraction 92015?
Yep, great question. Medicare does not require an ABN form be signed for non-covered services if it's marked as excluded or statutorily excluded in with the code itself. Solar refraction is one of those that is never ever paid. An ABN is not required. However, many practices get them because then the patient understands that they owe that money, but it is not a requirement. So you can collect that money from the patient whether you have it signed or not.
Great. And the next question is regarding ABN and refractions. Some Medicare secondaries pay for refractions and some do not. Do we still have all Medicare patients sign ABN for that?
Okay, so an ABN is not required for a refraction because it's never paid. So it just depends on the process in your office. If you feel that the patient has secondary insurance that may pay for it, not getting an ABN signed, the patient will ultimately still be responsible for it if the secondary insurance doesn't pay. Sorry, so Medicare is not going to pay for it. We're going to file it to secondary. Depending on their plan, they may or may not pay for it, but it should be denied as patient responsibility if it's not covered.
Okay, and the next question. Oh, sorry. And the next question is ABN needed for limbal relaxing incisions done same day as cataract surgery to correct pre-existing astigmatism?
Yep, an ABN form is required if you believe that service is not going to be covered by Medicare and it's not statutorily excluded. So in that particular case, I'd have to look up the code and everything, and I'm happy to do that. So if maybe you can get that contact information or email me, I'll be happy to give you an answer.
Okay, thank you. That was our last question. So this concludes our webinar. Just a reminder that a recording will be sent out within the next few days. And follow us on Twitter at iCareLeaders for summarized tips and action items from today's webinar. Thank you for joining and have a great day.